Hello, welcome to another lecture series. So today we are going to go through this uh, station, but this will be our after we do this station, the answers will be provided at the end of the lecture series. So the first question is what is the diagnosis? Second question, what is a chromosomal abnormality? Third is it's associated with. Also mention four features of this disease. Okay, so this question would probably you have to mention the conditions it's associated with. Then mention two antenatal tests you would order. So before we talk about the answers, we are going to literature. We are going to do a literature review. Since the diagnosis there is Down syndrome, so we need necessarily to understand what is Down syndrome, what does it come about. Then we answer the station at the end of the lecture. Okay. So Down syndrome. So children with Down syndrome are a diverse population, and there is a spectrum of features and associated disability, named after Langdon Down, who first identified the phenotype. It affects 1 per 1,000 live births in the United Kingdom. Then the underlying cause is aneuploid trisomy 21, and it is this addition of genetic information, including the critical region on the 21q22.3, which disrupts expected development, producing the dysmorphic features and mild to severe cognitive impairment. Then it is the most common chromosomal abnormality in the UK, and the prevalence, however, remains static since 1989 due to the selective terminations of approximately 90% of antenatal diagnoses. Okay, so that's the only downline. Okay, then let's talk about the genetics of Down syndrome. Okay, what are the genetics? So 95% to Down syndrome is as a result of trisomy 21, where there are extra copies of chromosome 21 in each cell. So instead of having the normal 46 chromosomes, there are 47, which have been demonstrated by this figure here. Okay. So on the chromosome 21, there are an extra copy. So instead of having the normal 46, there is actually another one. Okay. So meaning we end up having 47 XY, and there is an extra on the chromosome 21. Okay. So this abnormality occurs sporadically during cell cycle. So what's going to happen? So in a small amount of cases, about 3.5%, additional chromosome material is inherited from one of the parents who carries a balanced translocation, including chromosome 21. So one of the mechanisms this condition may come about is through a balanced translocation. Then the other one is even more infrequently, it may be secondary to mosaicism. So that's the second mechanism. Okay, where there is a mixture of some cells containing three forms of chromosome 21, while others are typical with 46 in total. Occasionally, in these individuals, a mild phenotype is expressed. However, this is actually variable. Okay, so technically, we have talked about three genetic causes. Okay, three genetic causes. Okay, so number one, we talked about the non-disjunction. Number two, we talked about the non-disjunction or trisomy 21. Then the other one, we talked about the balanced translocation. Then third, we also talked about mosaicism. So these are the three mechanisms of that can lead to Down syndrome. Okay, so let's look at the risk factors. So there is evidence that sporadic mutations are associated with maternal maturity. So for example, at 35 years, the risk is 1 to 270. jumping to 1 to 50 at more than 45 years. Then also family history. So if someone has the previous child with Down syndrome, there is an high risk factor. Okay, so those are the two recognized risk factors. So let's look at antenatal screening. So the majority of Down syndrome diagnosis will be identified on antenatal screening. So a combination test including biochemical markers in maternal blood, which is done between 2 to 14 plus 1 weeks, and a nuchal translucence on ultrasound scan, which is done between 11 plus 2 to 14 plus 1 weeks. So this provides a pre-test probability. Then you also have a quadruple test, which is offered to women presenting from the second trimester onwards. So if there is a risk of more than 1 to 150, invasive diagnostic tests are offered in the form of a chorionic villi sampling, which is less than 13 weeks, or amniocentesis if it's more than 15 weeks. So these actually carry a 1% risk of miscarriage actually. That's the only downline. Then the UK government has recently approved a new antenatal diagnostic test with a specificity and sensitivity superior to the current mode of testing at nearly 100%. So this measures cell-free fetal DNA, so cffDNA, present in maternal blood. So this is another test, cell-free fetal DNA. So this can actually be done earlier and with the hope of preventing the need for invasive and risk diagnostic testing later in the pregnancy. Okay, so this cell-free fetal DNA present in the maternal blood. So let's go look at the features of Down syndrome. So features of Down syndrome. So Down syndrome are also Down syndrome diagnoses are also identified postnatally, either due to a declined or a missed diagnosis or false negatives, which is usually 2%. So these babies may be identified by dysmorphic features. So these are the features with someone who have a small dysplastic ears, you have a flat nasal bridge, you have a small mouth with relative macroglossia, okay? Then you have a short stature, a short neck, and large nuchal folds. Then you have a single palmar crease, you have a brachycephaly, okay? Then you have a picanthal folds, you have an upward slanting palpebral fissures, you have brush-filled spots that are present. Brush-filled spots are actually present on the eye, okay? So Down syndrome, so those are not the only features, of course. The other ones we are going to talk about them. But here we are going to talk about the like the complications or associated problems actually. Okay. So Down syndrome is associated with the following conditions, and it is their increased incidence with which dictates initial management and subsequent health surveillance. So these are detailed according to the system. So we have visual problems. So one of the conditions is visual problems. So they may be born with congenital cataract, infantile glaucoma, strabismus, nystagmus. Then they may also have hearing difficulties, such as predominantly conductive hearing loss. Then on the ear, nose, and throat, they may have small upper airway spaces. So they actually have these small upper airway spaces. So what condition we will bring? So these small upper airway spaces cause increased risk of infections. So they have increased risk of infections, particularly group ear. Then you have the preponderance to obstructive sleep apnea as well. Then on the same obstructive sleep apnea, which is OSA, with the subsequent complications of daytime somnolence, obesity, hypertension, and eventual risk of co-pulmonary. Then on the cardiac abnormalities, which is affecting about 40 to 60% children with Down syndrome, they are typically found with an AVSD, okay? which is of course 20% of Down syndrome children and 25% of AVSD diagnosis. Okay, so those are some of the things you have to understand about the cardiac abnormalities. Okay, then on the respiratory, we can have recurrent chest infections due to a slight aspiration. That's number one, slight aspiration. Number two, due to impaired immune function. Number three, due to impaired immune function, specifically cellular immunity. Though this one, we can even add this same one, which is here, which is small upper airway spaces, with which can cause recurrent respiratory tract infection. Otherwise, these are some of them. Silent aspiration, impaired. So why is there silent aspiration? We have said silent aspiration because they have a small upper airway space. Then they also have impaired immune function. Then on the gastrointestinal complications or associated conditions, 7% of children will have GIT abnormalities, including esophageal atresia or tracheoesophageal fistula, duodenal atresia, and imperforate anus. Then the other condition in the gastrointestinal tract, which is slight increase in Hirschsprung's or congenital megacolon. But typically, worse outcomes of those actually affected. So these are some of the conditions that are present or associated with Down syndrome. Okay, so let's continue with the other one. So in the musculoskeletal, we have hypotonia, so particularly in the neonatal period, often manifesting with early feeding difficulty, increased risk of an atlantoaxial dislocation, which needs to be considered in children presenting acutely with neck pains. Then in the growth and development part, they may have a poor growth, short stature, which are common, and there are separate Down syndrome growth charts available. Then we also have developmental delay, which is actually universal but variable. Although some children may eventually live independently and gain employment, skills are likely to be acquired at a slower rate. In particular, growth, motor, and speech development, despite the level of the neurodisability and developmental impairment, children with Down syndrome are often socially very able. Okay. Then, in terms of endocrine associated conditions, they may have hypothyroidism. Okay. They may have hypothyroidism. Then the other one which they may have is hypogonadism as well. Okay. Then in the hematological part, can have unique to this condition is the transient myeloproliferative disorder (TMD), which is affecting about 5 to 30% of the neonates. Then, as the name suggests, this is transient, so usually correcting within 3 months. So there is a subsequent increase in the risk of acute myeloid leukemia as well. So these are some of the associated conditions. Okay, so what about the differential diagnosis? So antenatal testing identifies the risk of trisomies 13, 18, and 21. So this is actually Patel, which is the 13, Edwards the 18, then Down on the 21 respectively. Then phenotypically, these are distinctive from each other. So once a trisomy has been identified, further tests such as the G-band analysis, which will confirm trisomy 21. So it is important to carefully examine for features of Down syndrome when a related diagnosis is identified in order to differentiate whether they are distinct or part of a syndrome. Okay. So let's look at the investigation. So when there is antenatal diagnosis or higher clinical suspicion, genetics needs to be confirmed in the early postnatal period. So you have the DSMIG outline, which the DSMIG outline appropriate course of action for initial management of a neonate with Down syndrome. So much of the management is routine for all newborns, such as full newborn examination, ensure meconium and urine has been passed, and the review of feeding. However, care needs to be conducted with a high index of suspicion based on anticipated problems. Then early management includes senior pediatrician and midwife to attend to the family. Then a new educational initiative by Down Syndrome Association, which is a Tell It Right and Start It Right, urges those managing these families to have the correct and most up-to-date information in the early counseling phase. So, what are some of those investigations? So, number one, we have blood tests, such as the QF-PCR test. So, which is followed by a G-band analysis to identify trisomy 21. Then a full blood count, a blood film, so the DSA neonatal, okay, the newborn eye assessment, universal newborn hearing screen. You have a Go3 tests. So a Go3 test, remember we talked about hypothyroidism as a endocrine condition. So newborn blood spot on day 5 to screen for congenital hypothyroidism, a Go3 test. Then you can also do an electrocardiography and the echocardiography. So remember I talked about the AVSD. Okay, so an echocardiography will be very important in this case. Okay, what about management? What about management? So management, Down syndrome children are managed by a multidisciplinary team whose care is normally coordinated by a community of neurodisability pediatrician. So families will receive a personal child health record PCHR as an additional inset for the Red Book, which has condition-specific information with which to guide their care. Then other specialty import is dictated by associated comorbidities, for example, by cardiology, ENT, or respiratory physician and the surgeons. So what we just mean here is that when you are managing the child, it's actually a multidisciplinary thing. So if they developed other comorbidities, you have to include the cardiologists. If they have developed ENT or respiratory conditions, you have to include the ENT or respiratory physicians. If there's a surgical condition, you have to include the surgeons. Okay, then the overall aim is to treat any associated conditions, promote health and development, and reduce any disability or functional limitation. A routine schedule is advised by the Down Syndrome Medical Interest Group, the DSMIG. Okay, then this is a systems approach to identify possible growth delay, respiratory or cardiac problems, and investigations of thyroid function and the audiology assessment. So what's the figure we're talking about? Okay, so this is what we're just talking about, the blood tests and eyes, the blood tests, the newborn routine outbreak, the blood post spot tests. So this is usually done from age 1, and the thyroid function test will be discussed annually using the results of either the annual finger prick TSR test or the 2-yearly thyroid blood test, including thyroid antibodies. Then eye checks should be done. You have the newborn's routine check, including congenital cataract check. So this can be done at 18 to 24, where the form eye and vision examination, including check for squint and refraction for long and or short sight. Then age 4 can have a form eye and vision examination, including check for squint, diffraction, and assessment of near and distant vision and visual acuity. Then repeat vision tests every 2 years or more frequently if recommended by the optometrist or the ophthalmologist. Then the visual behavior should be monitored at every review, particularly in first year. Then we have hearing checks. So universal newborn hearing screen can have a full audiology review by 10 months, including hearing test and the impedance check. Can have also another one, which is the annual audiology review as before. Then you also have a 2-yearly audiology review or more frequently if recommended. Then for growth monitoring, we can have a length, weight, and head circumference should be checked frequently and plotted on Down syndrome growth charts. Then the height and weight should be checked and plotted on Down syndrome growth charts at least annually while growing. Then the BMI will be checked if concerned regarding overweight. Then art checks. So by age 6 weeks, formal art assessment, including echocardiogram, should be done. Then at all ages, low threshold for reviewing art status if signs and symptoms develop. Then from adolescent onwards, as part of the routine health checks, listen to the heart for signs of acquired heart disease. Then for the breathing checks, you have to ensure a daily review of uneven breathing during sleep or poor quality sleep. Then low threshold for further testing using sleep studies. Then lastly, the blood checks. So newborn blood test to check for abnormal blood film. So if the blood film is abnormal in the first 6 weeks, follow up for or repeat blood testing may be necessary until age 5. So there are instances where families are planning to subsequent pregnancies, so genetic counseling is offered, and a karyotype analysis would be performed to indicate risk of future offspring. Okay, so that is the table we are talking about. Okay, so this is one of the tables very common and that is usually used to assess children with Down syndrome. Okay, so let's look at the complications. So complications, we can have a life expectancy that is slightly reduced at 60 years, and there continues to be increased morbidity in later life. Then in particular increased incidence of Alzheimer's dementia. Then of course we can even add other complications such as or other associated conditions. So in short, the complications we can even add more using the associated conditions we're talking about, the hypothyroidism and whatnot, like Sprung's disease and whatnot. Okay. So let's look at now the case study answer. So this was our station, and the first question is, what is the diagnosis of Down syndrome? What is the chromosomal abnormality? Is the trisomy 21? It's associated with, so the risk factor, what is it associated with? Okay, it's associated with increased maternal age. Then mention 4 features of this condition. We can have a lower lying ear, we can have an abnormal small chin, we can have a round face, we can have a congenital heart disease, almond shaped eyes, of course, and of course others, the upward slanting palpebral features, and a short a flat nasal bridge. Okay, then mention 2 alternative tests you would order. So you can order amniocentesis, chorionic villus sampling, and percutaneous umbilical cord blood sampling, the pubs. Okay, then these are also some of the other uh, stations. So on the same station of Down syndrome can have with these ones. So the only thing which is different in this is this question, which is question 3. So mention 3 mechanisms that can lead, that you can expect to lead to this condition. Okay, so we can have translocation, mosaicism, and the non-disjunction trisomy. Okay, the non-disjunction on the trisomy 21. So those are some of the 3 mechanisms. Then the other one, the other station, the alternate station is risk for features. We have already the same ones we're mentioning. 2 risk factors for you are just going to put the increased maternal age and the previous history of a child with Down syndrome. Then 4 problems associated with this condition. Remember all those problems: the recurrent respiratory tract infection, hypothyroidism, hypogonadism, Hirschsprung's disease. A lot of those conditions we mentioned, they are the ones they want here. Then write down 2 features you will be looking for on each feet. So on the feet we have a sandal gap, so meaning there is a big space between the big toe. Okay, that's what we call a sandal gap. Then apart from the sandal gap, they have also have an increased plantar creases. So meaning usually on the hand they have a single palmar crease. What about on the foot? On the foot they have an increased plantar crease. Okay. So let me repeat. You have said on the palm they have a single palmar crease. Then on the feet, they have an increased plantar creases. Okay, so those are the two features we'll be looking for on his feet. Okay, so thank you for watching. If you subscribe and hit the bell notification, and see you on the next tutorial.